Hello, my name is Roger Henderson and I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us wherever you get your podcasts, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can also visit GPnotebook.com for podcast episode show notes. Now in this episode, I'm going to be discussing temporal arteritis, also often known as giant cell arteritis or cranial arteritis. But for this podcast, I'm going to stick with the term temporal. And this is a systemic vasculitis that primarily affects medium and large-sized arteries with a particular predilection for the extracranial branches of the carotid artery. And it's the most common form of vasculitis in adults over the age of 50, with a peak incidence in patients over the age of 70. Even more importantly, it's the most important medical emergency in ophthalmology because of the risk of permanent visual loss. Now, it has an incidence rate of about 15 to 25 per 100,000 people over the age of 50, and there's a fairly strong female predominance, almost 3 to 1. Now, cases in the under 50s have been reported in the literature, but I have to say these are tremendously rare, to the point where in some diagnostic criteria an age above 50 years is considered to be an absolute requirement for this diagnosis to be made. It's more prevalent in populations of Northern European descent, particularly in Scandinavian countries. And genetic susceptibility has been linked to polymorphisms in the HLA DRB104 allele, this suggesting an autoimmune component in the disease pathogenesis. Environmental factors, such as infections, have also been proposed as potential triggers for disease onset. But the bottom line here is we're still not entirely certain why it should occur. Now, a hallmark histological feature of temporal arteritis is the formation of multinucleated giant cells within the arterial walls, and these contribute to the destruction of the internal elastic lamina. The subsequent inflammatory response then leads to endothelial dysfunction, intimal hyperplasia, and vascular occlusion, and it's this that ultimately causes ischemic symptoms. And these symptoms may develop acutely or slowly, and the typical symptoms we'd all expect here include headaches, scalp tenderness, and jaw claudication. But constitutional symptoms are also common and can be forgotten about, and these include things like malaise, fatigue, weight loss, anorexia, and low-grade fever. Now we can further divide symptoms into cranial, ocular, systemic, and large vessel manifestations. So if we look at cranial symptoms first, headache occurs in about 2/3 of people with giant cell arteritis, usually temporal, obviously, but the location may actually vary, with the headaches being typically severe and unilateral or bilateral. When you talk to patients with temporal arteritis, they often describe the pain as being sharp or burning, certainly severe, and for most patients, scalp tenderness usually precedes these headaches by a few weeks. And this scalp tenderness is due to increased sensitivity over the affected temporal artery and can be severe enough to prevent simple actions such as combing or washing the hair. There may also be jaw claudication, where there's pain or fatigue in the jaw muscles during chewing, and this is a highly specific symptom indicative of vascular insufficiency. Now, the ocular symptoms we all worry about include transient or permanent loss of vision, often due to anterior ischemic optic neuropathy resulting from occlusion of the posterior ciliary arteries. And there may also be classical amaurosis fugax, with transient episodes of monocular blindness that are a warning sign of impending permanent visual loss. And I've personally also occasionally seen patients with arteritis present with diplopia due to ischemia affecting the extraocular muscles or their innervating cranial nerves. Now, if there's unilateral visual loss, there's also a 20 to 50% chance of the other eye also being affected. So those are ocular symptoms, but moving on to systemic symptoms, fever, fatigue and weight loss, although being non-specific, they are common in active disease. And also features of polymyalgia rheumatica, and I'm thinking of things like proximal muscle pain, stiffness and tenderness here, are present in about 40% of people with temporal arteritis. Finally, if we look at large vessel involvement, then aortic aneurysm and dissection can be a late complication resulting from chronic inflammation in the aorta, and subclavian and axillary artery stenosis can also lead to limb claudication and even asymmetrical blood pressure measurements. Now, when we turn to diagnosis, one of the key messages to remember here is that temporal arteritis is a medical emergency. Same-day secondary care referral should always be made, typically to a rheumatologist, for an urgent specialist opinion and for consideration of further investigations. Glucocorticoid therapy should be started immediately if there's any clinical suspicion of temporal arteritis, and it shouldn't be delayed whilst waiting for investigations such as imaging or biopsy. Now, temporal arteritis is a clinical diagnosis that's then supported by laboratory and imaging findings. And the American College of Rheumatology criteria include an age over 50 at the onset of the disease, new onset headache, temporal artery tenderness or even a decreased pulse, and an elevated ESR greater than 50 millimeters per hour. Now, less than 5% of patients with temporal arteritis have normal inflammatory markers, and so normal inflammatory markers do make the diagnosis much less likely and should make us consider alternative diagnoses, although they don't definitively rule it out. I think it's also important to remember that although ESR and CRP markers are highly correlated, and most patients will have elevations in both of these, I have seen non-concordance in temporal arteritis, and so it's important to measure both these inflammatory markers rather than just relying on the ESR alone. An abnormal temporal artery biopsy then shows vasculitis with mononuclear cell infiltration and multinucleated giant cells. And although usually considered the gold standard for diagnosis, this now may be preceded by ultrasound, and a biopsy should be performed on the most symptomatic or tender side, but it is possible for false negative results to occur. Now, with all those criteria, the presence of at least 3 of them yields a sensitivity of 93% and a specificity of 91%. But I mentioned biopsy as a gold standard test there, but more recently, ultrasound of the temporal artery has emerged as a diagnostic alternative for temporal artery biopsies, because it's a non-invasive test that can often be performed much more quickly and easily. And the presence of the so-called halo sign on a temporal artery ultrasound is highly specific for the condition and now appears in most diagnostic criteria. And this halo sign refers to a hypoechoic circumferential wall thickening indicative of edema of the temporal artery. And a positive temporal artery ultrasound may obviate the need for a biopsy. But because steroids progressively reduce the sensitivity of a temporal artery ultrasound, this must always be performed within 1 week at most of starting steroids. In patients where there's a high clinical suspicion of temporal arteritis and who have a positive imaging result, the diagnosis may then be made without any further biopsy or imaging. However, we should be considering a temporal artery biopsy if an ultrasound isn't available, or if the patient has typical clinical features of arteritis with raised inflammatory markers, but the ultrasound appears normal. If we look at other possible tests, these include magnetic resonance angiography and computed tomography angiography, because these are useful for detecting large vessel involvement. And there's also the snappily titled 18F fluorodeoxyglucose positron emission tomography, an FDG PET scan, that can assess metabolic activity in any inflamed arteries. So moving on to treatment, high-dose steroids are the mainstay of treatment here, and once the diagnosis is suspected, you should treat the patient with high doses immediately, and symptoms should rapidly improve after initiation of any corticosteroids, and if they don't, then give serious thought to whether the diagnosis is actually correct. We should give 40 milligrams of prednisolone daily unless the patient has ischemic symptoms, by which I mean jaw or tongue claudication or visual symptoms, and if there are claudication symptoms, we should give 60 milligrams of prednisolone daily. We can use pulsed methylprednisolone intravenously at 500 to 1,000 milligrams a day for 3 days in cases of vision loss, and if this isn't possible, then 60 to 100 milligrams of prednisolone for up to 3 days is an alternative. Now, the aim here is then to gradually taper the steroids down over 6 to 12 months based on symptom resolution and the inflammatory markers resolving. And any flare-ups or relapses that occur do usually respond to corticosteroid that are increased to the level at which symptoms previously were controlled. However, as we all know, glucocorticoid therapy can lead to significant toxicity in over 80% of patients with temporal arteritis. And if our patients are on long-term steroids, then obviously we need to give them osteoporosis prophylaxis. So if we then look at adjunctive therapies, these may be considered by a specialist in combination with the glucocorticoid taper in patients with arteritis who relapse, who have refractory disease, or who are at a high risk of glucocorticoid toxicity. Now, the interleukin-6 receptor inhibiting monoclonal antibody tocilizumab is effective in reducing relapse rates and in minimizing corticosteroid dependence. Originally approved by NICE in 2018 for relapsing or refractory temporal arteritis only, its use has expanded and is used now in the initial treatment of arteritis alongside steroids, especially in patients who are at high risk of glucocorticoid toxicity. Methotrexate may be used as an alternative to tocilizumab, for example in those unable to use tocilizumab due to recurrent infections, any history of GI perforations, or diverticulitis, and it can sometimes be considered first line as a steroid-sparing option because it's been in clinical use for longer than tocilizumab and is probably less toxic overall. Now, I think it's important to say here we should not be giving antiplatelet agents or anticoagulants routinely to patients with temporal arteritis, but these may be considered on an individual basis for selected patients who have vascular ischemic complications or who are at high risk of cardiovascular disease. Now, as we know, regular follow-up in these patients is critical to assess treatment response and to detect any complications such as steroid-related side effects. And I'm thinking of things like osteoporosis, hyperglycemia, and infections here, as well as aortic aneurysm surveillance, where serial imaging is recommended for patients with large vessel involvement. Now, the good news is that with prompt and effective treatment, most patients with temporal arteritis do achieve remission, but relapses are common, occurring in up to half of patients despite appropriate treatment. As I say, early intervention is critical to prevent irreversible blindness, which tragically occurs in about 15 to 20% of untreated cases. And the risk of vision loss after starting steroid therapy is about 1% for patients with no preceding loss of vision. In patients with impaired vision before starting treatment, that risk of progressive vision loss rises to about 13%. Interestingly, severe sight impairment in both eyes does appear to be rare. Now, the long-term complications do necessitate ongoing monitoring, as the risk of developing large vessel complications, such as aortic aneurysms, is increased. However, overall survival rates are similar to that of the general population. So that was a brief overview of temporal arteritis, and I do hope you found the podcast helpful the next time you see a patient and you're considering this condition. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook if you've any questions, comments, or ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.